really excited to be part of this webinar today, because we're delighted that our Frailty Improvement Programme is off the ground, but delighted that so many people are able to join us today. So we've got some really good presentations to take you through. What I would say, there will be opportunity to put some questions, but after each of the presentations. So we've got 3 presentations. So if you've got any questions, please put them in the chat. We're not going to take questions directly from individuals because obviously there's so many of us, but if you could put them in the chat, and we will endeavour to get back in terms of everybody's question. We might not be able to answer them all on the webinar today, but we will get back in touch with you in terms of responding to your questions. We're also going to have a poll at the end of and looking for feedback and evaluation on how you found the webinar today. But any particular questions, please put them in the chat. We are now going to record the webinar, so people will have access to see it later on, but just to advise you all, you are now being recorded. Okay, thank you. So thank you very much all for coming. We've got quite a busy agenda. We've obviously got an hour to get through this. So obviously our first presentation is from Joanne Payne, and she's going to take us through, and then following on to other presentations. And as I say, we're not going to take questions in between, we're just going to keep moving, but we will have questions at the end of the presentations. So thank you, and I shall hand you over to Joanne. Thank you.
Hi there. First slight issues, I can't find how I take control. Now that was really simple earlier on when I did it earlier on.
Joanne, if you could just look at the top of your screen underneath the title, and it says take control.
That was there earlier, but it's not there
now.
No.
If it's not there now, then Joanne, I'll just move the slides on.
Yeah. Oh, I'm so sorry. Good start. Sorry, everybody. So, as I've said, my name is Joanne Payne. I'm an occupational therapist. I'm an occupational therapy team lead, and for the last 2 years, I have led on the establishment of a new early frailty service. And what I'm going to do today is just kind of give a broad overview of the work that I've been involved in the last 2 years. Okay, can we move on to the next slide? So I will start. Oh, actually, that is allowing me to take control. Sorry. So I'm going to start by giving a bit of a background to the work. I'm going to move on to talk a bit about the service structure. I'm going to talk about how we've measured our outcomes. I'm going to touch on electronic frailty index and how we've used that, and then touch on slightly the very early work around impact on the wider service. So I suppose to start, historically and traditionally, occupational therapy services were very embedded in secondary care services. So we tended to become involved with people when they presented themselves at the front door of hospital, or if something reactive happened in the community, if they had a fall, or perhaps their memory had deteriorated, or they had a stroke. So traditionally, that's where our services were sited. There was some population level work planning services, but it did feel that was happening very separate to where we were sited. But there was an awareness from the partnership that without a shift in the balance of that care, then the system couldn't maintain the demand and we would continue to really provide very reactive services. So at the end of 2021, we got additional funding from the partnership to establish a new service. So we've got 6 assistant practitioners who are wrapped around services at a population level, and we've got qualified occupational therapists aligned to primary care settings doing early intervention work. So we did a number of kind of early pieces of work, and one of the earliest pieces of work we did was we had a look at the moderate electronic frailty list in one surgery in South Ayrshire, and I'll talk a bit more about the electronic frailty index later in the presentation. So we had a look at the 105 people that were sitting on the list, and actually we initially triaged 45 people out because they were either in long-term care or they'd had some physio, dietitian or some intermediate care input. Now, of that 60 people that we were left, what we were left with was actually a population of people who a quarter of them were not on EMIS Web, our community kind of documentation system. Just over a quarter had some light touch podiatry input, some had some ad hoc community nursing input, and almost 50% of them had no recent input or no physical health input at all. So that led to us having a kind of look at that wider 105 people. Actually, only 13 of them had actually had any occupational therapy input. So I suppose from this, we very much recognised that we were absolutely missing opportunities to maximise people's independence and their ability to remain at home. So as I said, we got funding for 6 Band 4 occupational therapy assistant practitioners, and we got funding for 6 qualified occupational therapists. Significant funding, absolutely. And this is very much, it's a two-stream approach to this. So we have Band 4 assistant practitioners creating networks in their community and building relationships, engaging with the community to encourage individuals to have early conversations about maximising their independence. We've also got the qualified occupational therapists who are aligned to primary care settings. And currently we're covering 10 out of the 18 practices in South Ayrshire, and we're currently in the process of establishing an 11th practice. So again, another early piece of work we did was we had a look and we established a driver diagram, and I'm not going to go into this in great detail, but it was a really, really useful way to kind of provide a framework for the work that we did. So the overall aim of the work was that there would, by December 2023, there would be an increase in the number of people over 50 who were identified as being frail at the primary care level, and that those individuals would have access to a specialist frailty assessment aiming to maintain or improve their independence. So it's a really useful way to identify what the primary drivers were, and the primary drivers were very much about creating that comprehensive evidence-based assessment. It was very much about identifying and engaging with stakeholders, working with the teams around the practices and supporting individuals to recognise that early frailty can be ameliorated in some instances. It was a really useful framework, and actually it was a really useful way to kind of identify ideas to test, and these ideas to test have changed as we've moved through the work. But actually, our latest test of change will be to do a pilot and training with care at home staff, and that is very much embedded within the HIS frailty improvement work. So, thinking about our service structure a bit more, there are various ways that somebody can come into the service. We keep that as broad and as easy as we possibly can. People can be referred into our service from any member of the GP practice. And that has taken actually such a lot of work, but worthwhile work. So that's involved a lot of relationship building, a lot of profiling what occupational therapy can offer, and a lot of profile around the merits, again, of having early conversations about frailty and trying to shift that perception away from a reactive service. So it's been really important to attend MDT meetings when we could. It's really important. We found that actually we've got visibility and presence in surgeries, and we have used the GP's record keeping systems as well, which is good for profiling what we're doing with individuals' patients. So people can come into the service from an EFI screening point of view, and again, I'll touch on that at the end of the presentation. People can come into the service from a self-referral point of view, so absolutely they can pick up the phone and phone the number at any point in time. And actually from an assistant practitioner point of view, 75% of the referrals are actually self-referrals. We also take referrals from other professionals. We've developed really close links with the professionals that are wrapped around us within health, but also from the third sector. So once they come into us, they will receive a telephone triage at that point in time, and we will decide at that conversation whether it's an occupational therapy-led assessment or whether it's an OT assistant practitioner-led wellbeing review. So the OT-led assessments will look at frailty indicators. They will do a core occupational therapy functional assessment, and they'll use standardised outcome measures and tools. Likewise, the OT assistants will do a wellbeing review, or they may, the third option there is that if they're well known to secondary care services and have been very active to secondary care services, then we may pass on to a community mental health team or a community rehab service. Now, from that conversation, an intervention plan will be made, and then outcomes are redone again. So this next slide is actually maybe not something that you can clearly see, but I just wanted to pop it up there because it's a really good visual way to map exactly the kind of networks that the assistant practitioners have been really driving forward. This has been the real focus over the last year to 18 months. And this is as vast as our imagination will allow. So we've been to lunch clubs, we've been to mobility shops, coffee shops, pharmacies, hairdressers, Ayr United Football Club. We've had pop-up stands at Dobies, we've had pop-up stands at local leisure complexes, and really built that network, and we continue to build the relationships with these groups. Now, some of these individuals have been happy to simply put our leaflet up. I'm just going to pop that up for you just now. That's our leaflet. So some of these places have been really happy to put our leaflet up, and actually some of the organisations, particularly churches, lunch clubs, sheltered housing complexes, have actually been really keen to have the team in to deliver healthy ageing talks and healthy ageing messages. So that's been.
Joanne, sorry,
yes.
Joanne, the slides aren't moving, so
Oh, they're not
seeing anything at all.
Oh.
Mine are moving.
I can see them as well. Yep.
So can I.
I don't know it might be my side. Then I'll see if there's something on this side, Joanne.
Sorry.
Sometimes you have to leave the webinar and then rejoin. I know that's happened in the past.
Yeah, it looks like, Joanne, that most people are getting them moved on. I certainly am too.
Okay. Where was I? Yeah, so the assistant practitioners building relationships in the communities, encouraging people to have early conversations around maintaining independence. So that's their kind of work. What we did very early on, again, was we developed 2 levels of assessment. So what we developed was a wellbeing review for the assistant practitioner staff and a frailty assessment for the qualified occupational therapists. We called it a wellbeing review purposefully because we really wanted to demedicalise that as far as we possibly could. But both of them are loosely based on the comprehensive geriatric assessment and his frailty indicators. Just got a couple of snapshots here. Happy to. Sorry. This is a snapshot from the assistant practitioners questionnaire that they do with people, and we tried to keep that fairly structured to support their intervention planning, because I think unlike traditional assistant practitioners roles, these are very autonomous roles. They're out there, they're in the community, they're seeing people without these people really ever having touched a member of occupational therapy staff. So it is quite a robust kind of structured assessment that is done with people when they go out. But it's really wrapped about what matters to you, conversation, and all of these things. And from these questions, we would generate an intervention plan. The qualified occupational therapist, it's again very much about a what matters to you type conversation. But we would go through all of the frailty indicators with an individual so that we can determine if somebody is self-managing an issue or if there is some clinical input that would support them to maintain their independence for longer.
Joanne, apologies, your microphone seems to have muted.
Oh dear. So, sorry about that. So what we knew very early on that it was going to be really important that we measured, and that we measured well. This is a framework that was produced by NHS England, and we used that as a framework to guide the development of the measurement of the work. The measurement of this work is challenging, as it sometimes is, but we had kind of three things that we really needed to remain mindful of. We wanted something that was absolutely person-centred. We wanted to keep that at the core of it. We wanted an outcome measure that really captured the essence of occupational therapy. So we really wanted an outcome measure that measured the impact on functional independence, because that is at the heart of what us as occupational therapists do. And we wanted to balance that because the outcome measure really needed to resonate with the wider primary care landscape. So we were trying to balance all of these factors out, but this very much helped us with that process. So we took a bit of a plan, do, study, act approach to the outcome measures. We tried and we tested and we changed. So we did have, and we still have, a monthly project meeting. But initially, early days, we had a session to consider how we would measure and what we would measure. And we considered the pros and cons of a wide range of measures. What we initially thought would be a good measure was the Canadian Occupational Performance Measure. Now, that is a very person-centred measure, and I suppose to reflect back to the criteria, the three criteria that we've just talked about, it's a very person-centred measure, and it's an occupational therapy specific measure. But the only downside of that against that criteria at the beginning is actually it's maybe not as recognisable to the wider public and the primary care landscape. So we were very conscious of that. We tried 5 Canadian occupational performance measures, but actually what we were finding was that people were struggling to kind of establish goals a little bit with it. It wasn't really done in a very standardised way, and we were very conscious that actually the impact of that might not be felt to the wider partnership. So we shelved that one, thinking, okay, what can we try next? I had tried the falls efficacy scale in the past in another piece of work. So that was also tested, but again, not everybody actually had a fear of falls. So actually, we quite quickly shelved that measure too. We had toyed with the idea of the indicator of relative need too, quite early in the project, but we shelved that early on because we were a bit concerned that it wouldn't be sensitive enough and that it wasn't, and it was therapist kind of rated, so we lost a bit of that person-centeredness. But actually what we did find was that it very quickly became apparent that it was showing impact, and to date, we've got 262 of those, and I'll move on to show some of the outcomes from our work in a moment. Finally, what became very apparent was that sometimes some of the referrals that were coming in were not really that appropriate. So what we kind of had a really good chat around where we sit with the best way to kind of establish what somebody's activities of daily living were like, so their level of independence. So we agreed to test and try the EQ5D. That's the Euroqual 5-dimension screening tool. And actually it looks at 5 dimensions. It looks at their individuals' abilities to do ADLs. It looks at pain. It looks at anxiety and low mood. It looks at mobility, and it looks at self-care. And it's a really useful way for people to rate how they're managing. It's rated, each question is rated out of 5. And what we agreed was that if somebody scored 15 or more on that, then actually it probably needed to be an occupational therapist that went out to see people. And actually the EQ5D seems to work really well. This next slide is just a snapshot of some of the outcome measures to date and the impact from them. We do score everybody in the Rockwood, and we've not seen much change with the Rockwood pre our intervention and post our intervention, but actually I think it's really useful in terms of a bit of a benchmark as to the type of patients that we're seeing. So I think we probably are targeting people who are in that vulnerable to mildly frail scale, and actually that's probably where we should be. As I said, we're using that EQ5D pre and post consistently now. The qualified staff are showing about on average a 21% improvement in that pre and post our intervention. But more interestingly, the assistant practitioners are actually showing a 30% improvement. So actually it kind of leads you to believe that maybe the earlier that we can get into people, the more impact we can actually have with them. We've also tested in a small way the self-management ability scale, which is a 1 to 60 scale, and the higher the number, the more awareness and the greater understanding of self-management knowledge there is. And we're seeing on average a 16% improvement in that, but we're finding the language in that assessment a little bit difficult for people to understand. So we're in the process of actually reviewing that one. Indicator of relative need. We have 262 of these now, which is quite a large number. It's an A to G lettered scale, with A1 being very independent and F being totally dependent. And actually it's pictorially quite difficult to represent that change, but I think the take home from this is that actually we're definitely seeing a shift in this. So before our input we had 27 Fs, and after our input that's now down to 2. And likewise there's been a shift in A1s as well, so 18 people sitting before our input and then 28 after our input. So showing some definite improvement. I popped this up just to give a broad kind of understanding of the type of things that we're doing with people. These are as broad as the imagination can go, but I suppose it also underlines the importance of training, and we've really invested in staff in terms of training and their skills in the broadest sense that we could. So we're still doing quite a lot of equipment provision, but that's quite light touch equipment provision. We're not talking complex pieces of equipment. We're talking perhaps grab rails or maybe a perching stool. We're doing a lot of falls prevention advice, referring for the community alarm, some mental health advice in terms of anxiety management, sleep hygiene, carer support, signposting to community resources and third sector is a big part of it, referring on to Invigorate, which is our local kind of exercise groups, goal setting, pain management, fatigue management and confidence building. So it's a wide range of interventions that we're actually doing with people. So to flick over now to the Electronic Frailty Index, for those who don't know, the Frailty Index is a 36 pointed model. It's 36 things that can actually be coded within the GP system. And the higher the number of items that people have got coded would result in a higher EFI score. It uses a kind of cumulative deficit model to identify and score frailty. So the higher the score, the increasing the frailty, the level of frailty is. So what it can support us to do is to put people in a bracket of mild, moderate or severe. So loosely speaking, under 4 on the Electronic Frailty Index would be kind of normal and fairly fit. Over 4 to 8 would be mildly frail. 8 to 12 would be moderately frail, and 13 plus would be severely frail. And you can see underneath that on a sliding scale, the higher that somebody's EFI score is, then the increasing risk of them to going into hospital. And these are average figures that were based on work that was done in NHS England, but actually Health Improvement Scotland supported further work in Scotland to make sure that could be validated and transferred to the Scottish system. So that's what we're looking at. And this work that we were doing with the occupational therapists aligned to GP practices is very much looking at those that are sitting in the moderate frailty section. So it was very, very early on, we knew that we wanted to do something that was slightly different around identifying people with frailty. We decided early on to do a pilot in one practice, and this links back to our benchmark work. So at that point in time, the Troon practice had 105 on the moderate frailty list. 45, as I said, were triaged out. And what we did was we sent a letter out to 60 individuals that were left, and 34, so a significant amount, accepted a frailty assessment. Those individuals were seen that their pre-EQ5D score was 12.7 and their post-EQ5D score was 10.1. So there was definitely impact from that work, and there was value in that. On average, interestingly, the Rockwood score was 4.5. So, but yeah, there definitely was value and impact from that. So using the Electronic Frailty Index, it's definitely not perfect. There's definitely variances in how items are coded. Sometimes mobility and falls and things can be coded differently. Sometimes they're not coded. So there's definitely variance in how they're coded, but I definitely found it a really useful way of proactively identifying individuals. And we're in the process at the moment of doing a further piece of work around developing quarterly reports from the EFIs in the surgeries in South Ayrshire, looking at individuals who have changed 2, 3, 4 points in a 3, 6 or 12-month period. So still work underway around that. Just finally, I wanted to finish off with a bit of the so what is the impact on the wider system? So what you're looking at here is a group of 29 people. The first 29 people that were referred through the one GP surgery in South Ayrshire. And these are the number of GP appointments that they used before in the 6 months before they were referred for a frailty assessment. So what we can see here is a definite shift from this point, from the 6-month period after input box. That is the same 29 patients and the number of GP appointments that they used after discharge from the frailty service. And what we can see here is a definite downshift. We've mapped that against the median, and the median before was 4. But we can definitely see after our input, we can see 2 sustained 9-point shifts in the data, indicating some improvement after. The median was re-evaluated after our input, and it's reduced to 2. So some very early indicators that there is some improvement, and we'll continue to drive forward and collect this information. There was no correlation with hospital admissions at this stage, but I suppose the hope is that if we can keep them away from GPs, then and hopefully we can reduce the risk of hospital admission. And that's the end of my presentation.
Thanks so much, Joanne. That was really informative and just really helpful in terms of how you went about it. And you know, as you say, that the so what bit is really important, isn't it? So what difference does this make? But you know, with your chat there, it shows, you know, there's a shift already, and hopefully that will continue to go in that direction. So lots of applauses there. Brilliant. Well done. Thank you. And just, I suppose, to remind everybody, if you do have questions, you can put them in the chat, and we will try and answer as many as possible at the end of this session. But if we don't get round to answering them all, then we will get back to you with particular questions. Okay, so we've got another 2 presentations to come, so we'll swiftly moving on. So Billy and David are going to take us through the next 2, and I'll let them introduce themselves properly. So thank you.
Good afternoon, everyone. I'm Dave Kelly. I'm Technical Director of Albasoft. We are currently exclusively contracted to NHS Scotland, providing primary care informatics services. I'll be playing tag team with Billy. I'll let him introduce him when he picks up from his slide. But if you want to move on to the next slide. This is some of our current project workflows that we have underway at the moment. Obviously, the one of the key ones is going to be the Spire Frailty transition. So that's now been, we now have a base model there that's been deployed out to every practice in Scotland, and we're moving through sort of final testing facilities and doing some minor changes just to get that up and running to make sure we've got it fully deployed. One of the other areas that we're working in at the moment is the pharma polypharmacy indicators. So this is more or less being run by the therapeutics branch. Obviously, when it comes to medication reviews, frailty is a fairly important part of this. That's the STU project is actually quite key because traditionally a lot of the frailty indicators have been modelled around clinical indicators, as you saw in some of the previous slides. But there's a gap there because there's a substantial amount of prescribing and pharmacy indicators that could actually supplement the general e-frailty solution quite substantially, and these sometimes tend to be missed when specifications have been drawn up. We're also about to start a fairly major project with NHS Highland, where we're going to actually combine both social care and primary care data into the one set. Particularly looking at the commencement of social care as a major frailty indicator. So that's going to be quite an interesting project where we can join both data sets. So we'll be starting on that one shortly, which we're fairly confident there'll be some quite good outcomes coming out of that one. And then the final project we have there was the NHS Lothian Anticipal project. Now, from a strict data science perspective, frailty does tend to be linear. It's not always linear, but in the majority of cases, you'll go from mild to moderate to severe. And then the extension on at the end of that is actually moving into pre-palliative and then palliative care. So as I say, from an informatics perspective, this is a logical linear extension on that. So it provides that additional capability there to move on to the end of frailty, to actually take it basically as a full pathway going from fit all the way up to palliative care. So that's 4 fairly important projects that are currently all interlinked, and they all, from our perspective, they all use the same mechanics. So all these projects, once they're up and running, and for the existing ones, can all be fairly easily interlinked to provide a much more comprehensive and holistic sort of view around frailty, rather than just using static sort of indicators on that. So I'll let Billy come in at the moment just to give us a wee update on what's happening with the Spire transition.
Hi, my name's Billy Davidson. I work directly for Brendan O'Brien. I'm a project analyst at NSS. I work directly with Albasoft, and I work directly with the primary care informatics team, which is a group of GPs and pharmacists that basically provide us with clinical assurance over the code sets that we build. I noticed that Keith Moffat's on this call. He's one of our GPs. Basically, we've been doing a little bit of work with Albasoft to replace the electronic frailty index tool that each practice had access to, as it was a Spire tool. Spire came to an end on the 31st of August this year, and we've been trying to replace their key tools since then. We are maybe 4 days development time off of delivering a replacement for the eFrailty index tool, but we're in talks with James Batty and others, to make sure that we're best using our time, because I realise that James and others are talking about perhaps moving to the eFrailty 2 tool, and some of my primary care informatics colleagues still want to do a little bit more of a deep dive on the code sets that were previously used for the Spire tool, because I think it was 10 years ago when the work was previously done, and it was the individual that did the previous eFrailty code sets that now wants to have a look at it, because she thinks that there are other things that we can include into basically these code sets and how we refine them. Basically, so as I say, we're going to work with we're going to work with our primary care intelligence service for Scotland, and PCIS is the new term for what was the ex-Spire development team. And we'll work very, very closely with them to make sure that whatever we put out to all practices in Scotland has got the clinical assurance that we require, and has been developed hand in hand with our PCIS colleagues. Dave, if you want to carry on to the next slide.
So as mentioned previously, one of the gaps that we sort of identified fairly early is there's quite a lot of work being done by the therapeutics branch around looking at a lot of the pharma indicators around frailty. So there's a fairly extensive system out there at the moment that will build up risk categories. Now, these risk categories also drive the proposed clinical decision support system. So there's, the categories around there, a lot of work around falls, around bleeding, around low BP that's actually available today that we could allow us to actually build over and integrate into the existing frailty reports. If you want to move over to the next slide. As was mentioned, there's around about 30 over 30 indicators that we currently use to build up that EFI score and to categorise everybody into a mild, moderate or severe category. Now, each of those rows actually represents one individual. Now, we're actually running that on a 24-hour cycle across a 5.6 million database. So virtually everyone in Scotland has an eFrailty score generated overnight, every night. So that's a very, very substantial data set. If you want to move over onto the next slide. However, the eFrailty component is only a very, very small part of all the indicators that we actually generate overnight. So although we're using around about 30 to look currently at eFrailty, there are 350 plus indicators in there. Sort of 60-40 between clinical and pharma. So all your multimorbidities in there, all your key prescribing groups are all generated as part of this individual health profile. So the eFrailty could easily be expanded out on a much, much wider platform than we're actually currently using it on. So there's a fair amount of opportunity there, and also the opportunity to start to build in some machine learning or AI capabilities to actually look at building up a much more condensed, a much more sort of comprehensive profile in there. The thing that we're working very hard on at the moment is to build up that confidence within the practices. So when a practice runs a report of how many people they should, whether it's medication reviews, social service reviews, or any reviews within a practice, that there's a strong confidence factor available when we're generating these reports. So it's in early days, but we have a huge amount of opportunity. And I'll pass back to Billy just for a quick overview on the new platform that we're planning.
Yeah, so up until now, we've been very, very bogged down from a resource perspective because we've got to go out to every single practice in Scotland and extract in a serial fashion any questions that we want to ask. And basically, any questions that we want to ask have got to be fully backed up with an IG case. We're looking to implement a thing called the Primary Care Data and Intelligence Platform. Again, IG will be a chief concern, and we need to put a very, very large IG wrapper around this. But what this will give us the ability to do is extract most coded data from all GP practices in Scotland. And then with each IG use case that we push forward, it will allow us, rather than developing and running a query over perhaps a 7 to 10 day period, it will allow us to run queries in a 10-minute slot and maybe allow us to modify those queries and test those queries very, very quickly and start to do an awful lot more what if analysis, which basically should allow us to get very, very agile at answering a lot of the questions that we get asked at the moment that we have to go back and say, I'm sorry, we can't provide you with that data because we don't have enough resources. So we're looking to put something in place fairly quickly to deal with our current workload, and we think probably around about March next year we'll have implemented and be starting to use the direct care component of this. And the direct care component of this can provide quite a lot of the detail back to our primary care intelligence service for Scotland, as in ex-Spire colleagues. So basically, the future's looking a bit brighter. We think once we get this platform up and running, we'll be able to answer an awful lot more of your questions and work more closely with people like Joanne. Joanne was mentioning in her initial call there that there was 25% of the population missing in terms of the EMIS community system. We can probably take that data set and tell Joanne exactly who's missing, and we'll be working with Lyle Cameron and Ayrshire and Arm to make sure that we start to plug these gaps in our information. That's me.
Brilliant. Thank you so much, Billy and David. That was, I think it is exciting, the fact that obviously there's going to be a lot more availability of that data and intelligence that you're talking about, that you know, really helps partnerships, organisations to predict, you know, where they should be going. So thanks so much. A lot we've packed into our hour today, so a lot of applause coming through to you all. Thank you. So hopefully we've got some questions in the chat box, and James and Diane are going to check those over and see what we've got, and hopefully we can answer some of these questions.
Yeah, of course, lots of great questions in the chat box. It's great to see them coming through. There's a couple of early questions, one from Scott Jameson about patient important outcomes, and another from Joe Gordon about the use of the electronic frailty index and the clinical frailty scale. But I think your presentation, Joanne, covered those quite nicely. So I'm going to skip to a question that came in from Michelle Miller. And Michelle asked, what one piece of advice would you give teams who are interested in setting up similar services in their area? So yeah, what are your kind of the key nuggets of advice you'd give, Joanne?
Wow, I think the most obvious thing that springs to mind is engagement with stakeholders. I think it's just been such a lot of work, but actually really, really important, because I think everybody needs to be on the same page about what you're trying to achieve and, you know, why it's so important. So that engagement has been really, really important. And time, I mean, there's two things that you know, we don't have an awful lot of time, but time is really important. The project meetings were really, really important in terms of really like working out those referral pathways and the information that we were going to use for assessments and the evidence and the wider information from, you know, HIS and stuff. So yeah, it's been really, really important. And I think at the end of the day, I think probably you can never engage too much with people. It's definitely been a new type of engagement for us as well. So it's thinking about that engagement in the wider sense. And actually, it's interesting, it's probably maybe 2 years too late down the line, but we're actually just in the process of pulling together a communication strategy about how we then move that even further. I hope that answers it.
That's great. Thanks, Joanne. Diane.
Yeah. I've got a question here for Dave and Billy from Roberta. It's how do we access the EFI scores for our patient population in general practice with a vision system?
Right, every practice has a small escrow utility called the vaccination import tool. So at the moment, we were going to look at rebranding it, but the e-frailty tab is available on the vaccination import tool. So the practices run that tool on a daily basis to import their vaccinations. I know it's an odd place for it to end up at the moment, but if you just ask the practice to open the vac import tool, you'll find the e-frailty tab is there.
So as I suggested earlier, this still requires further development. So I would encourage you not to use that tool at the moment. It'll give you individual patient data, but it doesn't give you the report summarization that was provided by the previous Spire tool. That'll happen very, very, very shortly, and we'll basically let each practice know at that point that we've done a new release of the tool. So as I say, it's not completely ready at the moment. Dave's point about basically renaming the vaccination import tool, it took us a long time during the pandemic to point every practice in Scotland at the vaccination import tool. There's probably about 11,000 people that know it and use it, and I'm quite keen, and they were quite keen not to change the name, so as we could point at a working entity.
That's great. Thanks for those answers, Billy and Dave. Another question here for Joanne from Victoria Mulholland, who's asking about communication with secondary care and the links there.
So yeah, I mean, I think fortunately my my previous post was managing the community rehab team. So we've got really good links in with them. We meet with them fairly regularly. So we kind of do have regular sessions where we are communicating. We're also starting to collect data on the impact that our service is having on referrals into secondary care, and it's a bit too early to demonstrate, but there's definitely a bit of a shift downwards in terms of those referrals. But I think it's about relationships, and it's about engaging people. Yeah, keeping communicating with them. And again, it is a new way of thinking for staff in terms of that whole proactive input as opposed to reaction. It's a new way of thinking for staff, and it's about trying to embed that message and the importance of. Thank you.
Thanks, Joanne. Diane?
Thanks. Yeah, I've got another question for Dave and Billy here. Who would eventually have access to these new data platforms? And would integrated partnership data analysts be included in this access?
Yes, I think it's the easy answer to that. So as I say, we're going to stand up a thing called the GP editorial board, and the GP editorial board will be basically a GP from each of the LMCs, and an extra one from the RGPC, and an extra one from academia. And those GPs will work to get consent from all 896 practices for us to use their data on a use case basis. But really what we're looking to do is set up a domain zero, which will be direct care only, and then we're looking to share the data on a use case basis with all of the boards, Public Health Scotland, our list colleagues, and anybody else who needs that downstream data that's got a legitimate use for that downstream data, and the IG in place to do so. I know that's a big answer at the moment, but lots of work taking place on there, and we'll keep you up to date as we progress that.
That's
Thank
great.
you. James, did you have another one?
Do we have time for another question? I think we might move on to the closing remarks now, Anthea, so hand back to you. That's okay.
Yep. Yes, thank you, and thanks for all your questions going into the chat. But yeah, thanks very much to Joanne, Dave, and Billy today for the presentations. Have been really informative. Even me sitting here chair, and I've heard a lot of it before. Each time you hear it, gosh, it's just another bit. So really helpful. I think, as always, Healthcare Improvement Scotland are always keen to improve. So if we could get some feedback from yourselves from that regarding the webinar today, there's a QR code there. We would really appreciate you just taking a little bit of time, just a few minutes, to complete the evaluation, because it does help us planning and organising future webinars, try to get the timing right, the content, context and things. So it would be great just to get some feedback around that. But thank you so much. We've had over, I think I was counting, about 445 people attending today, so that's we're delighted about that. So you know where we are. We've just put up the contacts for us, but please feel free to get in touch, and any feedback would be welcome, and any thoughts, ideas for the future too. So thank you everybody, particularly to Joanne, Dave and Billy for their presentations today.